All right, today we're going to tackle a really fundamental but so often misinterpreted concept in advanced electrocardiology. We're talking about concealed conduction. Now, this is an electrophysiologic phenomenon that is just a master of disguise. And trust me, understanding it is absolutely critical if you want to avoid some pretty significant diagnostic errors. So here's how we're going to break it down. We'll start with the basic principle of what concealment even is. Then we'll get into how it creates these deceptive rhythms that look just like AV block. After that, we're going to dive deep into three fascinating clinical cases. And finally, we'll wrap up with the key diagnostic takeaways that you can apply in your own practice. So, what is the principle of concealment? At its very core, concealed conduction is all about an electrical event that's happening inside the heart, but it's just too small. Its voltage is too low to show up on a standard 12-lead ECG. The catch is, even though you can't see the event itself, its consequences, its downstream effects, are not only visible, they can be incredibly misleading. To get really precise here, when we talk about concealed conduction, we're usually talking about a premature junctional depolarization. On a His bundle electrogram, you'd see this as an H prime beat. Now, think of this impulse as being trapped. It fires, but it doesn't have enough juice to conduct forward to the ventricles or backward to the atria. So because it goes nowhere, it's totally invisible on the surface ECG. But, and this is the key part, by depolarizing that AV junctional tissue, it resets the clock, right? It makes the whole area refractory. So how do we know it happened? Well, we infer its existence from what it does to the next beat. That's where you see the effect, a suddenly prolonged PR interval or even a completely blocked P wave. Now, while we're really going to zero in on those premature junctional impulses today, it's worth knowing that the term concealed is actually used in a few other contexts. For instance, we talk about concealed bypass tracts. Those are pathways that only conduct electricity backward or retrogradely, so you'd never see them during normal sinus rhythm. It also applies to what happens in atrial fibrillation, where tons of atrial impulses bombard the AV junction, get blocked within it, and that's part of what creates that classic irregularly irregular rhythm. Okay, so now let's explore how this principle creates such a huge diagnostic headache. This is where concealed conduction really earns its reputation as the master of disguise in electrocardiography. So you're looking at a surface ECG, and the pattern you see might scream Mobitz type 1, Winkevach. Or even more worryingly, it might look exactly like a Mobitz type 2 second-degree AV block. But the underlying mechanism, what's actually happening under the hood, is completely different. It's not a sick conduction system. It's the after effect of a sneaky, concealed, premature junctional impulse that just made the AV node temporarily refractory. And let's be really clear, this is not just some academic distinction. The clinical stakes here are incredibly high. If you mistake concealed conduction for a high-grade AV block, it can, and unfortunately sometimes does, lead to a patient getting a permanent pacemaker they absolutely do not need. So being able to spot this impersonator is just paramount to avoid causing serious harm. All right, let's transition to our first case file. We're going to meticulously deconstruct the surface ECG and hunt for those subtle clues that blow the cover on the true diagnosis. Okay, take a look at this tracing. The first thing that jumps out at you are those multiple blocked P waves, right? Indicated by the up arrows. It's immediately concerning. It looks a lot like a Mobitz type 2 block. But look closer. The critical finding, the absolute key to this puzzle, is the presence of those frequent, visible, junctional premature complexes, marked by the down arrows. The moment you see those, your whole differential diagnosis has to shift. Let's use a ladder diagram to see what's really going on. In strip A, focus on the junctional impulses labeled J2 and J4. These impulses manage to conduct backward. They capture the atria, and that's what creates those inverted P waves, P5 and P11. But they fail to conduct forward to the ventricles. So what's the result? You get a P wave just sitting there by itself, which on the surface looks exactly like a blocked beat. Now check out strip B, because this is the main event. Here, the junctional impulse J6 is fully concealed. It doesn't capture the atria, it doesn't capture the ventricles, it's a true ghost on the surface ECG. But by firing, it depolarizes the junction, making it refractory to the very next sinus P wave, P18, causing it to be blocked. I mean, this is a perfect, brilliant imitation of a type 2 second-degree AV block. And then the next impulses, J7 and J8, go on to create a pattern that looks just like a 2-to-1 AV block. If we dig even deeper into this tracing, we can find some other cool stuff. See how the T-wave morphology changes a bit? That's because the length of the preceding RR interval has a direct impact on how long it takes the ventricles to repolarize. And why are some of those junctional beats not conducted? Well, it's because they happen to be preceded by a longer RR interval, and that longer pause actually lengthens the refractory period of the conduction system that follows it. Oh, and that missing R17 complex? Don't get thrown by that. It's just an artifact from the paper folding. You can see the little T-wave there, which confirms the ventricle did in fact depolarize. So for our second case, we're going to move beyond just making inferences from the surface ECG to looking at the definitive proof. We're going to examine intracardiac recordings from a His bundle electrogram, which let us see these hidden electrical events as they happen. So get this, these Holter strips are all from a single patient, and they show the incredible variety of ways this phenomenon can present. In strip A, you see this sudden out-of-the-blue PR prolongation. In B, you see a pattern that looks for all the world like a type 1 Winkelbach block. And in strip C, you see what appears to be a classic type 2 block. It's just amazing. All of these are being caused by the exact same underlying issue. And here it is. This is the smoking gun. On the left, you've got the surface ECG from strip C that looks like a type 2 block. But on the right, you have the simultaneous His bundle recording that reveals the truth. Look, right there, immediately before that blocked atrial beat, you see it? A premature His depolarization. The H prime, that is the concealed event now made visible, proving that it is the reason for the block that follows. And these other His bundle recordings just nail the case shut. In strips A and B, you can see that these same concealed H' impulses are also what's causing the sudden PR prolongation and that Wenckebach-like pattern. So this is unequivocal, invasive proof that this one single mechanism is the culprit behind this whole range of apparent AV conduction problems. Our final case really hammers home just how serious this diagnostic challenge can be in the real world. This is an alarming finding during a routine treadmill stress test, a scenario where you have to make decisions and you have to make them fast. This quote from the case report really says it all. The development of a high-grade AV block while a patient is exercising is a major red flag. The immediate thought is that this has to be severe ischemia hitting the conduction system. And so, yeah, they appropriately stopped the test. So here's the tracing that set off all the alarm bells. What you're seeing is this consistent 4-3 conduction pattern that looks exactly like a Mobitz type 2 second-degree AV block. Seeing this while the heart is under increasing stress, well, that's deeply concerning and it demands immediate action. But the question is, was it really what it appeared to be? And once again, the ladder diagram shows us the true mechanism. It's a concealed junctional premature beat causing the apparent block. Now, this case gives us another really elegant, subtle clue you can see on the surface. Notice the shape, the morphology of that blocked P wave. It's just a little bit different from the other sinus P waves. Why? Because it's an atrial fusion beat. The atria are being depolarized at the same time by both the sinus impulse coming down and the junctional impulse going backward. That slight change in P wave shape is a powerful, non-invasive clue that there's a concealed junctional event going on. All right, we've gone through some pretty complex cases. Let's distill all of this down into a set of actionable principles so you can recognize this great impersonator in your own clinical practice. Okay, to sum it all up, you have to maintain a high index of suspicion. The number one clue is seeing manifest or visible junctional premature complexes on the same strip as the apparent block. You should also be really wary of any AV block that comes and goes or changes its pattern. Always scrutinize the shape of those non-conducted P waves. Are they a clue for atrial fusion? Any unexplained sudden PR prolongation should also make you pause. And finally, remember that those subtle changes in T-wave morphology related to cycle length can be another hint that something else is going on. And really, this all leads us to the final and most critical question. The real challenge is making this call at the bedside with just the surface ECG in your hands without having to do an invasive EP study. But by meticulously looking for the subtle clues we've just talked about, we can dramatically increase our diagnostic accuracy and, most importantly, protect our patients from getting invasive procedures that they just don't need.